It is a huge, unbelievable honor today to be podcast interviewing an actual dentist who works for the Centers for Disease Control in Atlanta, Georgia. How cool is that? You've been working with them for 17 years?
I've worked as an employee for 17 years, and for the last 15 years have been a contractor and subcontractor for CDC, so it's been kind of fun.
Wow, you're putting my podcast on the map. I mean, I'm usually just podcast interviewing all my hillbilly friends, and now I've got someone from the Centers for Disease Control Atlanta. That is just truly amazing. So, how did you end up going from dental school to the Centers for Disease Control? How cool is that?
Well, it was a lot of fun. It was one of those things that just kind of happened. I was in Charleston, South Carolina, caring for patients, Gullah patients on the Sea Islands in Charleston, and was on faculty at the dental school. And I applied for a job at CDC, and it was to do work actually on fluoridation. And when I got to CDC, there was this new disease. It had been called GRID, or gay-related immune disorder. And shortly after I got there, it was renamed AIDS. And we all know that there was a lot of interest in AIDS, and because of that, there was also interest in what kind of infection control practices to perform to safely treat patients with AIDS and HIV, the human immunodeficiency virus. So I had a really interesting time learning about the new and emerging science at that time. That was very, very exciting. So it was fun.
One of my top 10 favorite movies of all time was about AIDS. It was called "And the Band Played On." Did you ever see that movie?
I did.
And what did you think of that movie?
Well, it was interesting because I knew some of the folks who were in it, and I loved the way that they portrayed Dr. Mary Guinan. She was one of the few women who was involved in the early part of the epidemic, and Dr. Jim Curran, who was actually my boss for about 5 years. So sometimes they were, and Harold Jaffe, who was also in that movie, I know pretty well. And some of the portrayals were pretty accurate, and some of them were a little bit overdone, but I think the excitement about the early part of the epidemic and how doctors and patients worked together to transform the approaches to the disease and discover things about the disease, that was new and different. Because at the beginning of the epidemic, only a bunch of epidemiologists and geeky people like me would read the Morbidity Mortality Weekly Report. And as time went on, it became patients were reading it. People who cared about their family members were reading it. So we were all working together, and that was kind of fun. That was exciting too.
And when did that epidemic actually break? Was it 79?
Well, it probably existed before 79. There was a hepatitis study, but it was really the first cases were reported at CDC about 81. And so, there were actually cases before that time, and we've got cases now, I guess, back to the 50s and 60s, because they've gone back and done some look-back studies. But there was a hepatitis B study in San Francisco that had been ongoing, and the really first cases of AIDS came out of that study, as well as some independent doctor case reports, when doctors had cases of patients who had this constellation of disorders that they hadn't seen before in young, healthy men. So it was very interesting. We were all learning together and working together collaboratively. It was kind of fun.
And did you know Don Francis in the movie?
Oh, sure.
Was he portrayed pretty accurate?
Well, we used to call him Saint Don, but I think in that movie he was portrayed a little more saintly than he was, but he was certainly, I think, someone who continued to advocate on behalf of patients and the people he cares about.
But the big question is, Alan Alda from MASH played Dr. Robert Gallo, and they did not portray that man very nicely at all in the movie. Was that accurate?
I would say that some of the portrayals were accurate, and I'm not sure I could argue with that portrayal.
Yeah, kind of an arrogant egomaniac.
Well, I would just say that Luc Montagnier might agree with that, and there's a lot of history behind their rivalry, and I think at some point in time there were scientists who decided that Luc Montagnier deserved more recognition than he had had. So I think there's another story to be told about that as well.
Well, I think if there was any takeaway from whatever we talk about today, that if my homies never saw that movie and the band played on, you got to go back and watch it. I think it's just an HBO movie. I don't think it's on Netflix, or I never found it on Apple TV. I just had to go set up my computer on the internet and Google YouTube, and the band played on and watch it off HBO. I don't even know if that's legal. I'm probably giving illegal advice, and they're going to come penalize me with that. But yeah, just a phenomenal movie.
It is, and I think it's really helpful, because I was thinking about doing another lecture called From AIDS to Zika with Ebola in Between, because it was a very exciting time at the early part of the AIDS epidemic, as we were discovering. And AIDS is a global pandemic, but it also makes us realize not only how vulnerable we are and how we need to work together collaboratively, but also it lets us know that we can learn and quickly disseminate information that's life-saving. I think there's a second story that can be told about not only the AIDS epidemic, but some of the newer epidemics that we're dealing with right now with Zika. And that story that has to be told is how, working collaboratively, we can overcome some of these diseases, and particularly what we've seen with tamping down on Ebola in West Africa. And also, I think the story of the 17 new drugs that got approved to treat people with AIDS in the in the late 1990s, there's a story to be told, and I think there's another movie on that, because that everyone working together to get speedy approval of these life-saving drugs, and I think it ought to be not and the band played on, but how we all work together to combat a global pandemic.
We are so off topic with what we were going to talk about today. I just want to keep going off topic. What did you think of Friday night when Bill Maher gave television time with Charlie Sheen's doctor when he went to Mexico, went off his HIV triple cocktail, and is trying some unproven method in the United States? It almost sounded like the Americans. Well, what did you see it first of all?
No, I didn't see it. Send it to me. I'll take a look at it.
Yeah, it was. I'll just read you the deal. It was Bill Maher gave airtime on his show Real Time with Bill Maher to a so-called doctor who is unlicensed in the U.S. and promotes a scientifically unproven cure for HIV. The Australian, who claims to be a doctor and practices in Mexico, has been receiving scrutiny after HIV-positive celebrity Charlie Sheen revealed he went off his antiretroviral drugs to try Chaco's so-called cure. The treatment consists of consuming the milk from arthritic goats, which is neither scientifically proven nor approved therapy. But I thought that was stunning, because I mean, Bill Maher is a huge journalist for 20 years. It's on HBO, and so you didn't see that?
No, I didn't.
Ryan, email this to her right now.
Yeah, if you go to the internet, there's lots of conversations about unproven methods. In fact, there was actually some political leaders in South Africa who thought that HIV was not the virus that caused AIDS and promulgated that in a particular country, which will remain nameless for right now. There's a lot of unproven techniques that have been out there to combat not only HIV but all kinds of other diseases, and I would just say that there's proven scientific methods, there's clinical trials to test that is time-worn and proven to be helpful to individuals.
I just want to read your bio, Dr. Scarlett. Dr. Margaret Scarlett, an international lecturer, author, clinician, and public health dental leader. Dr. Scarlett is a noted infectious disease and chronic disease expert. As the author of the first infection control guidelines from the Centers for Disease Control and Prevention, CDC, she now focuses her career on caries assessment and management for populations. Beginning her career providing oral care to the proud Gullah people of the Sea Islands below Charleston, she has been a professor and director of dental research at one dental school and head of the hygiene program. Her most recent accomplishment was training over 100 healthcare workers for Ebola Treatment Unit infections control last year for the CDC. Wow. So you wanted to talk today about new approaches to caries assessment and management, or what did you want to talk about?
Yes, I wanted to talk about caries. Caries and periodontal diseases are the two main diseases that we deal with in oral health and dentistry. And I think what's so exciting about it is that we're finding out so much about the biology of it right now. I think that we have some real ways to prevent it. So if I could say what the formula is, and I'm an old
I
chemist.
bet don't tell me what it is. I bet I can guess. It's swishing with coconut oil for 20 minutes every day.
Oh no, this oil pulling is all over the internet. Oh my gosh.
Hey, I read it on the internet, so it has to be true.
No, please. Let's
I
use
think that's so funny that they can't brush for 2 minutes, but now they're going to swish with coconut oil for 20 minutes to pull the toxins out.
No. It's not been proven. We need to use the scientific method, the clinical trials, the proven methods, And most people don't know what clinical trials are, but they're a fairly lengthy multi-year process to test different items that can either prevent or treat different diseases or are used for not only drug testing but for vaccine testing. So there's a phase 1 test where you test for safety on healthy volunteers with a small number of people. There's a phase 2 testing, which is testing for safety in the individuals impacted by the disease. And then there's the phase 3, which is a much larger study, usually thousands, that tests the efficacy or the effectiveness of the vaccine or drug. And that's the proven scientific method. So you want to look for clinical trials data. There's not any clinical trials data that I've seen on oil pulling or coconut oil or anything else. So, but I think it points to something too. Caries impacts about nearly every person on the planet. WHO says that caries impacts nearly 100% of the population. We think about infectious diseases in this way. Anything that has over 50 cases per 100,000 is an epidemic, okay? That's the way CDC thinks about it, all right? But we're talking about something, caries is a disease that impacts 90,000 out of 100,000, or maybe, as WHO says, maybe 100,000 out of 100,000. That tells you the scale of the disease is pretty great among human populations. So I got pretty excited when I started looking at the new science behind caries, and that's why I wanted to talk to you about today.
Well, let's talk about it.
Yeah. So, the message that I'd like for people to take home is detection plus remineralization is actually real prevention. And, CDC is the prevention agency. I think it's one of the things that excites me about this new biology is that we have an opportunity as oral health providers to prevent disease. How about that? And that's kind of fun. So I'm going to review a couple of things that might be useful and might be helpful to people. Let me see if I can get the slide.
Did the CDC change its name to CDCP, Centers for Disease Control and Prevention, or did that not stick? Because I remember them adding a P for prevention, but I never really see people refer to the CDCP. They still only refer to the CDC.
Yeah, that's
What's
true.
the real name?
The real name is the Centers for Disease Control and Prevention.
So it's CDCP.
Yep. Well, but we don't use that.
So you still call it the CDC?
Yeah, and when I was at CDC, in the very early years, it was the Center for Disease Control, and that was it. And then it became the Centers for Disease Control, and then it became the Centers for Disease Control, and they added and prevention because it was the prevention agency. And CDC's mission is to prevent and detect diseases. So there's a group of individuals who are called epidemiologists, who are kind of the lieutenants of CDC. And if you've seen Outbreak, you've seen this training that people go through at CDC to detect and understand diseases in populations.
And that movie's called Outbreak?
Yeah, go check it out. Yeah.
Okay.
Yeah, they filmed some of the zombie movies too at CDC, so you get some views of some of the labs. Yeah.
Right on.
So caries, I think one of the things, like I said, that excites me about caries is that I can take what I learned about AIDS and even working in chronic diseases and nutrition issues and breastfeeding issues among women, and not that those are diseases, but there's assessment systems for those. And we haven't had a really good assessment system for caries, even though it affects nearly everyone. So that's kind of what I wanted to talk about today. We've used some crude methods that are pretty old and not really designed for today's ways of thinking about disease. And so what I'm excited about is the opportunity to share with you what scientists around the world, dental scientists, oral health scientists, biologists, and others have come together to really think about caries in a different way. So I'm going to see if I can share some of the slides that I created. So I just want to say that I'll be talking about assessing and managing caries with biology and evidence, and that's kind of the theme of what I'm talking about today. Yeah, so I was a contributor to the Surgeon General's Report on Oral Health 2000, and the Surgeon General's Report on Oral Health stressed the importance of good oral health, but they also talked about the fact that caries is pretty much of a universal condition, that only about 50 or 60% of individuals go to the dentist any particular year. So we're missing, 40 or 50% of the individuals who don't go to the dentist. So what do we need to be thinking about? And so we need to be thinking about understanding the biology and change our thinking to managing caries in a new way, and helping patients to understand how we can manage caries in a new way, and using evidence to manage caries. So there's something called the triple aim that's being utilized across health, which is just a concept. It's pretty long in one way, but it's also very practical in another way, which is to think about that health should be what is going to work for a large group of people, which is what you have, a large group of people impacted by caries, and think about their experience of care as well as the evidence and the cost of it. So there are some costing measures which makes reversing early caries pretty reasonable. And you can be sure that the insurance companies are looking at this. They're looking at it. This is just some data. I can't see this very well, but it shows the cost savings when sealants are used. When a person gets sealants at age 12 or 13, and the cost savings by the time they're 19. And so the insurance companies are definitely looking at this triple aim, and not only cost savings, but really preserving tooth structure. And that's kind of the new way to think about things too. When I was in dental school, I can't tell you, every lecture on caries was referring to G.V. Black, and boy, in his day, he was terrific. But I think we've got to move beyond that extension for prevention. That's an old concept, and think about the whole idea of detection, and remineralization is prevention. So that's the new sort of word for today. And when I go back to what I like to do, which is to look at population-based health, we have to think about a population-based approach to oral health, kind of a dashboard view, and really think about it with a sense of urgency. If nearly everyone is impacted by caries, and we're going to have 4 million more children covered under the Affordable Care Act for pediatric dental benefits by 2018, we don't have systems in place to take care of all these folks. There's really been no progress in more people visiting the dentist within the 10 years, in the last 10 years from 1999 to 2009, according to the National Center for Health Statistics at CDC. And then there's really persistent disparities in terms of access to care. If you're well-to-do and you have dental insurance, you're much more likely to go to visit a dentist in any year than someone who doesn't. And there are also disparities in terms of race, ethnicity, and culture. And I don't want to get into the issue of workforce issues and models, but we know that there's a lot of diverse opinions about that, and what their role should be. But I'll talk a little bit later about the fact that we've got a lot of medical professionals who are now being reimbursed. Pediatricians and nurse practitioners and physician's assistants in many states are being reimbursed for basic diagnosis and early intervention with fluoride varnish among children in many states for public programs. I think the other sense of urgency that I have is that the use of evidence-based practice is underwhelming. We know a lot, and there's been individuals like John Featherstone at the University of California, San Francisco, who's been a champion for talking about caries risk assessment for many years and the balance between various factors like diet and saliva and oral care at home and also at the dentist's office and fluorides. And he's talked about these balancing factors, but we haven't really utilized that in many places, sometimes in dental schools and sometimes in practice. But if you also look at our decay rates, yes, we've done better in the last 50 or 60 years than we had been, but there are many countries in the world that have much lower decay rates than we do in the United States. And kind of the last thing is that measuring caries and talking about it among different professionals is very difficult because of the measures that we're using, which was something called DMFT, which I'm not a fan of, decayed missing FLT. So it's it's something I want to tackle today, and I want to say that in terms of detection, in the past, our visual detection and radiology and instruments were used to detect caries. Well, today we want to use evidence. I mean, this is an evidence-based world that we live in, and there was a lot of consternation back in the early 90s. I remember when I was at CDC and on a daily basis, and that was pretty funny because a lot of physicians were calling up CDC and saying, oh my gosh, these scientists are trying to tell us what to do and how to practice, and there were articles in the New England Journal of Medicine and other places that talked about this issue. But I think that people have begun to calm down in the medical world about the use of evidence and are seeing it as a tool. In fact, I've seen doctors scurrying out of the patient room and checking out an app with the latest evidence from the Cochrane collaboration or whatever, PubMed or whatever, to look at the latest information and the latest evidence. And they're using that along with their clinical assessments and laboratory assessments to provide the best possible patient care. So I think about evidence as a tool. We know that the biology of caries indicates that caries is not a binary process. In other words, by binary, I mean you either have it or you don't. It's rather a progressive disease, and we know that from the biology. So if you look at reviews of visual caries diagnosis, and Jim Bader did this back in 2002, and Ahmed Ishmael did this in 2008, the diagnosis has been critical of those methods of visual detection, radiology, and instruments to detect caries. So we pretty much know that. And we also know that the use of these traditional methods where detection or decay is cavitation have been found to be either outmoded or insufficient given what we know about caries. We know about caries, and I'll talk about that in a little bit in a minute, but I know that Nigel Pitts in 2004 and August Dodd has also done some extensive work on looking at these outmoded or insufficient ways of looking at caries with DMFT. And if you look at a comparison of the International Classification and Disease Assessment System with the WHO basic methods of assessment on primary teeth, they found out that if you use this new system, ICDAS, ICDAS-2, that you could detect a greater number of lesions with these new detection systems or new ways of measuring. And let me just say that the best evidence that I've seen was at the European Caries Association meeting, which incidentally we don't have a Caries Association group in the United States, which is interesting. But the Europeans have been meeting together for quite some time, and I found their meetings really fantastic. There was data presented there that the national surveys in Malta and Portugal, with Paulo Melo from Portugal, who is with the Portuguese Dental Association, and they demonstrate that using this old measure of DMFT, which was designed as a screening tool way back when, it underestimates caries by as much as 33 to 100% among children and adults. So, that's the evidence that I've been looking at to think about new kinds of assessments and a new way of thinking about things. Now, why does this really matter? Okay, who cares? You know what I mean? So we don't detect the earliest caries, and we don't actually treat all the caries that's out there. But I think that we're really not thinking about the costs in a broad-based way. There's been a lot of cost shifting of untreated dental decay to both the medical system and to society. And now, because not only of the Affordable Care Act, but because of rising health costs, people are starting to look at this cost shifting issue. And you can see that in surveys of the emergency room in Oregon and Washington State and Maryland, Florida, and others, and show that the tooth pain and these codes 521 and 522 are pretty frequent. And that's even with underreporting and missed codes, because sometimes codes are put in because they'll put facial pain, because that might be reimbursed by a particular system, where dental or tooth pain will not be. And then there's also the cost shifting to society. There's this cost of missed school and work from tooth problems, dental decay, but also, of course, periodontal disease, and the cost of poor school and work performance. It's a huge cost to society when mom has to miss work and take her child out of school. This is impacting a lot of students there. And then there's the cost of missed economic or lost job opportunities or connections. It's hard to measure that, but it is a cost that is there. And if nearly everyone is being impacted by dental decay, that's a huge issue. We know biology, this is interesting to me too. There's some interesting projects looking at the human biome. And we're understanding more about the biology now than we ever have, and the characterization of the oral biofilm is so interesting. You get this wonderful graphic, I think, from I think this one was from National Geographic, where you get the initial attachment. You just have a couple of cells, or a few disorganized cells, and then there's a growth and proliferation. And then there's a detachment of these, and they kind of throw out small seedlings, which then go to other areas and repopulate in those other areas. And I think that this human biome and the biofilm and our understanding in its relationship to caries is so interesting. And this is kind of a view here. If you look at what's the impact of this biome, well, the biome then has waste products, and it produces acids, and that actually demineralizes the tooth. And if you look at this diagram, which is an iceberg, it produces these subclinical initial lesions in a dynamic state of both demineralization and remineralization in this gray area that's on the slide. And that's what you see. The biofilm is actually in a dynamic state. It's attached to the tooth itself, and it's demineralizing, which the strongest substance in the body. Horrible plane crashes or in horrible events such as what occurred with the World Trade Towers, teeth were often, and pieces of jaws were used to identify people. And they're very, very hard substances. But the byproducts from this biofilm is so strong that it actually can demineralize the tooth. So then we move to a clinically detectable enamel lesion. And that's usually what when it's limited to the enamel, we think about that as very early decay, and then when it gets into the dentin, that's usually the point in time where we're treating, so that everything below this waterline is not being treated with most current techniques. Now, there are a few dentists who do treat, but by and large, we're just treating the iceberg here, but not below and these other areas. And we probably have to do more of that. So the new system to kind of classify it, called ICDAS or ICCMS, International Classification Disease and Assessment System, as well as the International Classification Management System for Caries. And so this shows it, and I don't know if you can see this pretty well, but the subclinical lesions are at the very, very bottom. Again, and they're pretty large. Okay, there's a large number of these. But this is the dynamic state where these subclinical lesions, which are only in enamel, could be reversed with the proper lesion. And that's what I'm excited about. Then you see the visible enamel decay, some of which could be remineralized, some of which are beyond the point of remineralization. And these are also can be treated. Then you start to look at visible dentin decay, and that's usually, again, the area that we're treating, and then pulpal decay. So these are the ones that patients usually complain about or they're able to detect. And we're kind of missing this whole other area at the bottom of the pyramid. So that's why I think this new system, this ICDAS, which uses a 0 to 6 point or 7 point scale, and I don't want to get into the measurement issues so much today, but just to point out that this huge area below of subclinical decay, where we can remineralize, is what I want to focus on, because we as dentists know how to take care of these things. But wouldn't it be nice, since we have so many people who don't know about reversing early decay and preventing, we've got a lot of work that we can do to prevent decay so that we can take care of more patients who need help with the frank cavitation and decay later on. And I just want to say that the FDI, the Federation of Dentary International, has a global caries initiative, and they have really looked at some of these systems too for assessment. And G.B. Black, everyone knows this, but the disadvantage is it's 100 years old. It underestimates caries. There's no way to address progression, which is part of the biology. And if you look at the WHO systems, it's accepted, but it underestimates caries. And I think that when you listen to Professor Pitts from King's College in London, who has really spearheaded the ICCMS efforts and ICDAS systems at both King's College and with Dr. Ishmael at Temple University here in the U.S., I think that you see that that education about early lesions has really been underreported, and I think that we need to focus more on that. The ADA has come up with a caries classification system which collapses some of the numbering system from ICDAS, but again, it hasn't been validated. Mountain Hume has some clinical standards, which some of us like, and as a clinician, I like it, but there's limited data about its effectiveness. And then there's the French have used some site stage classification system. So I think that none of these systems have really been validated, but I think we need more work to validate caries, particularly in light of the efforts that have come out of both Malta and Portugal. So I'm just going to leave the whole issue of assessment and say that we can do better, and I think the best system right now is the ICDAS, ICCMS, and we need more work on validation for the U.S. Yeah, there's a lot of remineralization agents, and I didn't include all of them. Some of them you know and know well, which is fluoride. We've been using fluoride, but we're probably not using all the fluoride that we need to use and at early enough stages. We know that caries is a process that also it's an infectious disease process. Let's think about that, and that's something that is of interest to me. It starts pretty early after birth. We don't talk about that very much, but it is transmitted from mother or caregiver to infants very, very early in life. And also there's been lots of studies that show that there's what we call horizontal transmission, which is transmission from, say, siblings or other children in a daycare center who transmit the bacteria that cause caries to other children. So mothers transmit the caries bacteria to their children, what we call vertical transmission, very early in an infant's life. And then there's also horizontal transmission, which is siblings or other children transmit the bacteria to children very early in life. And we know that preventing caries in primary teeth is very important. And we know that fluoride varnish provided very early in life, say 1 year old or afterwards, can be very, very helpful in preventing decay at the very earliest stages. There's also a lot of other remineralizing agents, and I don't really have time to go into all of those. You know, that's another hour-long lecture. But ACP has been, amorphous calcium phosphate has been shown to be pretty effective. Tricalcium phosphate is in Clinpro and some others. Xylitol has been. I'm not going to go into all of them, but there's some evidence on xylitol, if the dosages are correct, that it also can be helpful preventing caries. So I think that there's a lot of information that's continuing to come out, and looking at the evidence again, looking at clinical trials evidence, and looking at the reviews on these remineralizing agents is really important to reversing early decay. That's the message I want to get across, is that we as dentists can reverse this. We have been doing that anyway. With fluoride, most of us have delivered fluoride treatments for a long time and will continue to do so. But it's really thinking about this in a new way in terms of reversing early decay. So I just want to say that, kind of in summary, that early caries can be reversed, and actually with remineralization. And the new methods of managing caries use evidence, and the evidence has been summarized in December of 2014 with ICCMS from Dr. Pitson and Dr. Ishmael, and I would encourage people to go take a look at that. There were a number of secondary authors, including myself as a very small role, but this is an important document. It's too big to be summarized, and there are many people who are much better experts on the ICCMS than I am, but I believe that this is the new way in which to manage caries for the future, and we need to think about how to translate this into clinical practice, and also get reimbursed for it, because it's important in terms of saving money for patients, saving time, saving tooth structure. Patients are not aware of remineralization. They may be aware of fluoride from some of the advertisements on television, but generally they are not aware of the ability that we have to actually save teeth and save tooth structure. And I think that that's something that is a new message for the future, and that is real prevention. So you can help patients prevent early cavitation. You can help to prevent decay. I know that many of us are skilled in treating decay once it has been, it's into dentin, and we've got lots of techniques, and we've got a lot of focus on that. But I think we've been missing the boat in terms of the early caries. And when I see some of our colleagues in the other health professions, like pediatricians and physician's assistants and nurse practitioners, who are starting to work on diagnosis and treatment of early decay among young children, I think that it's something that we can take a lesson from and utilize this with all of our patients, including adults, to remineralize teeth. So it can be managed just like any other infectious disease so that it doesn't become chronic, and that we can interrupt not only the transmission issues at some point in time, but also to remineralize teeth and actually safe tooth structure. So I wonder if you have any questions for me.
Well, that was an outstanding presentation, and the most obvious takeaway is that we've been treating dentin decay and pulpal decay with root canals, and we need to start trying to treat enamel decay.
Oh yeah, exactly. And we haven't even been measuring this. So, I think that's the real important takeaway message. We've been using an outmoded system that doesn't really make sense. So I think it's time that we look at the very earliest stages at which we can reverse decay, help to get more of those 40 or 50% of the population who never makes it to the dentist in a given year, and let them know that we can actually prevent early decay or reverse early decay in enamel. How about that? That's a new message. That's real prevention.
A couple of times you said there were other experts in this field, and then another time you said, to talk about that would take an hour. Would you ever consider creating an online CE course for Dentaltown? We have 210,000 dentists from every single country on earth, and we put up 350 courses, and they've been viewed over 500,000 times. Do you think that you or the CDC could ever go into more detail with an online course on Dentaltown?
Oh, sure. I can't say about CDC, but I can say for myself that that I would be happy to really talk a little bit more about oxidize-2, the measuring system, as well as the clinical issues around early detection and early remineralization. I think it would be important, and we could do it in a couple of different ways. One is to look at the evidence around some of these things. If you think about the detection device, and we've done this in other areas, and I've done it with many other items, we look at two things called sensitivity and specificity. Sensitivity is one part of it, and specificity is another part of looking at the devices that we want to be able to use. And you want both high sensitivity and high specificity. That means that the number of false negatives and false positives are very, very low, okay? So we could go over some of the science, as well as look at the clinical data, the clinical trials data for remineralization agents. And I don't think many people have looked at. And I looked on the literature, there's a couple of reviews, there's been some international conferences that have looked at this, but it hasn't been related to the assessment of where the caries was. So if it was in an enamel, there were different ways of measuring it, there was lack of consistency, the studies were really small, but I think that I could help guide people to how to think about evaluating whether to use these agents in their practices or not. Yeah, for sure.
That would be so exciting, and it would be so prestigious for our online CE course to have someone of your stature creating a course for us. That would just be completely amazing.
Well, you're kind. I would be pleased to do so, and really help give people some rulers about evidence and how they can make assessments about evidence for themselves in their practice.
I want to ask you one question before I let you go regarding water fluoridation. I've been involved with that my entire career. I was on the water fluoridation campaign in Phoenix originally in '89. We had to do it again 20 years later when it expired. And it just seems to me that the growing force of people that are just so against this, and I mean, they just seem to get louder and louder and louder. It seems like there's more anti-community water fluoridationists today in 2016 than there was in 1989 when I first got involved with it. Do you agree with that, or do you disagree with that? Do you think it's still worth the fight to stand up to all these people? I mean, it's a conspiracy. It's a government plot. It's this stuff is so toxic, they have no idea where to get rid of it, so they bribe government officials to pour it into the public water supply. They take a blog from they find studies, arcane studies in China and Iran that didn't get picked up on any other like PubMed that are showing that it's toxic, things like this. What is your view of water fluoridation all these years later?
Well, it's highly effective at reducing early decay and remineralizing teeth when decay is at the very earliest stages. And it's also across income levels, so that poor kids benefit as much as well-to-do children, so that it's across the population. Again, it's back to population health. It's very, very low cost. It's not as expensive as a visit to the dentist, and it has been shown to reduce decay significantly in study after study after study. Now, I'm always a proponent that we need more studies. The early studies in Kingston and Newburgh are pretty outdated. We really need another study like Kingston and Newburgh, because we get other sources of fluoride. And I think because the government has reduced the standards from 1 part per million to 0.7 parts per million, it's confusing people, and there haven't been great messages and good communication about the benefits of community water fluoridation. But they're pretty clear. And in studies, especially in other countries, we've seen fluoridation is highly effective at reducing decay. We need to get that message out. Yeah, it's worth the fight because it can reduce decay and reduce that early decay. So I think that you see a lot of misinformation out in the airwaves. But I think it also presents us with an opportunity to educate people because they're interested in what's in their water. We've seen horrible situations like in Flint where people didn't know what was happening. And I think the more people educate themselves about not only what's in their water, but what's in their air and in their environment, it's important. But we can honestly say, looking at the science, that fluoridation in the water is highly effective in reducing decay. And so I think it's important. But we also need to continue to study that.
Well, Scarlett, thank you. Is that why the CDC hired you? Because they wanted, after Scarlett O'Hare and the Gone with the Wind, when you applied for the job at CDC, they said Atlanta, Georgia wants another Scarlett.
Perhaps so. You'll have to ask them.
But but Margaret, seriously, thank you so much for giving me an hour of your time today, and I would so love to have this in a online C course on Dental Town. And the neat thing about Dental Town and the internet is as many kids would be watching this in Kathmandu or Malaysia or Singapore or Ethiopia as they would in Atlanta, Georgia. And it would just be a great. You have a great message from a great career in infectious diseases and everything. And I would look so forward to that.
Well, I'll be happy to do it, and I'm looking forward to it. Thanks very much, Dr. Friend.
All right. Thank you, Margaret. And I hope to meet you in person someday.
Me too.
Okay. Bye-bye.
Bye-bye.
We'll have a glass of fluoridated water together.
Yeah, maybe in Chicago where it's fluoridated.
Okay. Bye-bye.